Hello, everyone. Welcome back to another episode of Vet Wrap. Yay. Now, today's really exciting because we're going to talk about saving dogs' legs and what is truly a world's first clinical trial using synchrotron radiation therapy for soft tissue sarcomas. Now, that's a whole lot of big words. That was scary. To my left, I have Dr. Alette. How do you say your surname?
Engels is fine.
Engels is good?
Australian
All right.
way, yeah.
All righty. Alette, I've written down here, but you are a researcher specialising in synchrotron microbeam, but you're more than that.
Yeah.
You're a radiation oncological, the hell? What are you?
Oncology medical physicist now. I'm starting to get trained clinically as well.
So what is that job?
Yeah,
you fry people with radiation.
No. So, physicists or the engineers, they've got to know all the technical stuff behind all the radiation machines at the hospital.
Yeah.
So are they giving what they say they're giving? Are they outputting what they say they are? So we're looking at more of the technology behind it and making sure it's outputting the right thing. So your CT machine as well.
Yeah.
Same deal, the dose, how it's working. Is it going to give you the right images and the right, care for the patient? So that's the physicist role. We have to also talk to everyone else. So all of the radiation oncologists come to us when they have some technical problem. Maybe an artifact problem as well, like motion or dental implants or something funny like that. And then the radiation therapists come to and talk to us as well about the planning. So
you don't
right in the middle.
You don't do the planning.
Do some planning, but not all. Yeah,
okay.
Not all. Yeah.
And you did advanced maths at school.
Oh yeah, I love my math.
Cool.
So would have loved to have done anatomy and then gone on to medicine. So I've kind of fell into medicine in my own way, but I love the math too much. So I had to take a bit of that problem solving and apply it, I guess. So
cool. Good.
Yeah.
Now to my right, I have Dr. Eleanor Woolley.
Very formal.
Yes, it is, isn't it? Considering Ellie's one of the residents, works with us at ERH. And ultimately, though, that big mouthful about using synchrotron radiation for soft tissue sarcomas, why did you and I sort of geek out and get really excited about this? What's the issue?
It's pretty amazing, really. Well, we've been looking at all these dogs going around with these lumps forming on their legs in particular, which are, even when they're small, really hard to remove, get rid of them completely. Like soft tissue sarcomas are, tumours with low metastatic potential. They're not really going off spreading too far and wide very commonly, but they do really invade locally. I don't think I've ever discussed this with you. I always picture these things as little fat octopuses. They sit there with little tentacles that spread off that no one can see. So you've got the lump that you can see, but then also this other microscopic disease.
Did you have a cuddly octopus toy as a kid?
Not that I can remember.
We'll get you one.
Like a pet octopus.
Okay, we'll get you one.
Anyway, these are octopuses or octopi we don't like and we're trying to get rid of. But the reality is to try and cut them off, especially on the distal limb where you don't have a fascia underneath to actually get a deep plane, means you often will end up either not being able to remove them or having to remove the dog's leg to get rid of them.
Yeah, so hang on, I'll just stop you there. So there's obviously a difference in how you cut a lump off. Yeah. So there's just a local excision.
Yeah.
And then there's oncologic. The idea of wide excision is a bit misleading, isn't it?
Actually try and cure them instead.
Yeah. But the deal is you either cut them off incompletely and tumours like soft tissue sarcomas will grow back, or you cut them off curatively, which is oncologic, but that means you have to have enough space side to side, but the right tissue underneath, what we call the fascial plane, And so the problem, as you were saying, is that say on, over here on my wrist, I have skin, but underneath the tumour is bone.
Exactly.
And what happens if you take out the bone? Cut off the leg. No leg, So the clinical problem is we don't like cutting off legs.
No, we're trying to save these dogs' legs.
Yeah. So what do we do now today? Like, you have these in the clinic, you do surgery. So what is our management plan at this point? We're not always hacking off legs, are we?
No, definitely not. So we will originally be biopsying them to see what grade they are, because they do come in sort of grades 1, 2 and 3, which is a low grade, locally invasive versus higher risk of more metastatic potential. The lower grade, the 1 and 2s, if you can actually cut them off and try and get an oncologic excision, then they've got really low chance of growing back. So we will be looking at them individually and quite often having to take them off with the best deep margin that we can and then dealing with a skin graft to try and heal that area.
Yeah.
So it's a long journey to take a pet and an owner on for something that...
Well, but it doesn't feel good, does it?
No.
Because we do these surgeries, we look owners in the eye and say, well, we're doing an oncologic excision, inverted commas, knowing that in truth we're probably not achieving what the rule book says we should do, knowing that we're going to leave the dogs with a significant wound, which will need, in many cases, skin graft or a complex axial pattern flap, like a reconstruction of some sort, and that can be really prolonged. And we're thinking about how prolonged that management is, knowing that we might not have achieved the outcome.
Exactly.
That's the struggle, isn't it?
Yeah. We
Which
sort of look at them going down to here. We're okay. We've got fascia on
that's
as
right.
soon as we get lower down.
Yeah.
So we really have tried to focus on those ones that are distal limb, beneath the elbow, beneath the stifle.
And our other choice is to look people in the eye and say, if you want a definitive cure, we're going to amputate the leg, which no one likes, us particularly. So, we're rocking a hard place, isn't it?
Yeah, exactly.
Yeah.
And we seem to have stumbled into a world of amazing things.
Well, along came Alette. Yay, Engels. and saved us. Or maybe, we'll find out. So, Alette, because I don't really get it still, and I've been at the synchrotron quite a few times, what is it?
Yeah.
What is the radiation that comes out of it? I'll give you 3 things because it's too much to remember.
Yeah.
And why don't we just go and use a medical radiation unit called a LINAC generally, aren't they? Yep.
Yeah, no, good question, good start. So the synchrotron itself in Clayton, actually, so local to Melbourne, where we got a big synchrotron. I think there's only 2 or 3 in the Southern Hemisphere, so Australia's got one. And really it's actually accelerating electrons, so subatomic part of the atom, those electrons whizzing around the atom. We actually turn them around in a giant circle at the speed of light.
About the same size as an AFL footy pitch.
Exactly,
This monster.
football field, that's right. And synchrotron's made out of, I think, recycled Colorbond, so pretty Australian. We've got this all going on in a shed, pretty much.
Really? I didn't know that bit.
Yeah. And so then we make these like really high energetic electrons. And if you bend an electron, you tend to get X-rays. If you do that, it decelerates. And by doing that, it releases some of that energy. And we actually take those X-rays and we use them for all kinds of things at the synchrotron. So they can do X-ray crystallography, they can look at fluorescence, far infrared. There's a whole spectrum that comes off these, and it's really useful for so many applications in science. It's like, I guess, a scientist's playground to work over there. It's really
So those big words basically result in you can image pretty well anything, can't you?
Yeah,
you
so that's us. We're imaging. That's our application of it.
Yeah, you can push these things through concrete blocks, can't you?
Yeah, too right. So there's a lot of X-rays that come off this. So X-rays like what you have out of your CT machine, but so much brighter, so much more packed into that. And so we have a really high, what we call flux, so a really bright amount of beam that we can use. So that means if you were imaging, you can get your imaging done super fast. We can image the first breath of, babies. We've seen like premature baby studies to see the first breaths being taken.
Oh, wow.
And it's really amazing.
Cool. Yeah.
We've done endangered wildlife as well to understand images and like deep down in tissue what's going on structurally and functionally, including Tasmanian devils and emus and all kinds of things, and even sharks to see how they mature and grow. So pretty much sky's the limit, and even space. We've had an astronaut suit come across and they were looking for damage after being in space. So and then down to the earth and fossils and all kinds of things. So we can get 6 micron kind of size pixels, which is so tiny. You can imagine like your hair is 50 micron. You can go beyond that in
Well, the
time.
fact that you mentioned
So
they're
the
looking
deep-
at split ends with
That's a good
L'Oreal,
story.
I think, came as well.
Yeah.
That's
That-
right.
Tell us that one.
Yeah,
so
yeah.
that, like, for me, that was a great picture. So L'Oreal came to you guys.
Yeah.
And that's why you know that your hair is 50 micron.
I mean, I'm a physicist, so we usually measure hair with diffraction. So you put it in the path of a light beam and you can see the interference pattern on the wall, and you go over and measure it, and that tells you how big your hair is. You can do some calculation. But at the synchrotron, you can actually image it. So you can go to that level and actually make a physical measurement of someone's hair and how good apparently shampoo or conditioner is to fill up the hair follicles.
And did it?
I don't know. It was a bit before my time, but I hear it was some good data, but I also think it's confidential. I don't think they want us to know the secret.
Damn it.
I'm not sure. I'll have
Put you
to
on the
find
spot.
out. It's all good.
All right. So we've just talked about the imaging and
that's
so
the synchrotron.
basically whizzes electrons around a great big
Yes.
circle, super fast.
Yep.
so fast that they're brighter.
Yeah,
How many times
really-
brighter than the sun?
Oh,
Some
right. No, so speed
crazy-
of light, but in terms of an X-ray that you'd use out of your CT machine, it's probably about 1,000,000 times more bright or high, rapid, I suppose,
Yeah.
the intensity, how
Yeah.
quickly it can be delivered.
Yeah.
So, yeah.
So that's the imaging side of things, but we're not doing that, are we?
No,
We're
that's right.
saying, hey, radiotherapies exist,
Yeah.
and the modern radiotherapy unit is a linear accelerator.
Yes, yeah.
This is synchrotron is a
Yeah, a bit different,
Yeah.
different. So I'll definitely talk on that. So yeah, not only can you image, but X-rays, as we know, can be used to treat cancer.
Yeah.
So you're essentially passing this type of radiation through. There's a lot of radiation around us, but this type is very energetic. It will interact with the DNA in your cells.
Yeah.
So the idea being that you would exploit a kind of weakness in the tumor cells, that they're more susceptible to radiation and that damage. They can't repair it as well as the normal tissue. Normal tissue is very established and has some mechanisms that it can use to repair. So we're trying to take advantage of that with radiotherapy. And when you're going to a LINAC at the hospital, you're using a bit of a higher energy to get through the body, but it's also slower. So your patients could be sitting there for a while, depending on the type of treatment they're getting. And even if it is a kind of shorter dose of radiation, they're coming back for 6 weeks. So
Yeah.
coming back every day, and they get a small portion of that for weeks. And so the difference is that the synchrotron, like I mentioned before, we've got such a bright source. And at the imaging and medical beamline of the Australian synchrotron, where I was working, they have the ability to do that what they can in the hospital in less than a second. So
Wow,
you can
okay.
imagine patients coming in, sit there, bam, it's over before you blink.
The full course of
The
treatment,
full,
1 second.
yeah,
So
exactly.
is that because there's so much more energy in the synchrotron one, or
Not
because the
energy,
patient
but brightness,
Brightness,
yeah.
okay. I'll never get that, but
That's all right.
so much brighter
Yeah, yeah.
that you can deliver. The term's greys, isn't it?
Yeah, exactly.
You can deliver
Greys.
all the greys, or is it because the tolerance is so much better, or is it both?
It's a bit of both, actually. Yeah. So that's what they're finding nowadays. We found that a bit by accident, actually. So we just think, if we're going to deposit energy from a beam to damage a tumor, we're going to do that in energy. So, in calories or joules, it is that. It's joules per kilogram.
Yeah.
So you're putting in joules per kilogram, which is a grey.
Yeah.
And then at the clinic, you're getting 2 grey, usually, each fraction up to maybe 60 grey over the weeks.
Yeah.
But we do that in one punch. And what we find is if you have to sit there for minutes and minutes and build up that dose, we get more tissue inflammation. We get this like kind of, your heart is beating, the tissue is getting constantly, refreshed with that. And we get more potential for inflammation. That's the base level. There's some theories going around about oxygenation as well, and how repair could be different too when you're treating rapidly. But this is something, really exciting that we kind of stumbled across, in that if we deliver quickly, we prevent a lot of the normal tissue from overreacting,
Yeah.
I guess. But the tumor seems to be still reactive, which is really good. So we're still punching that energy into the tumor. Yeah.
Because in really simple terms, I think of the Chernobyl documentaries, and you stick 60 grey into someone in one sitting, and they're gonna
Yeah. Yeah.
the hair's gonna fall out, and they're
Oh,
gonna
for sure. If it's your whole
skin's
body,
going to flake off and all the rest of it.
Yeah.
So that's because you can do it so much faster.
Yeah. Also smaller.
And
Yeah.
what do you mean by that?
So in part of that, I wouldn't give your whole body that kind of dose.
Yeah.
I still don't think that would be good. Even if you
Yeah.
did it quickly, it's still a lot of energy,
Yeah.
no matter what. So then what do you do? Even when you're targeting cancers around the body, even with the LINAC, they will try and shape that beam to spare as much of the normal tissue as they can. So they're going to shape that while it's rotating around the patient. They're going to do different angles to minimize the dose that the normal tissue would get. And it's all about preventing that dose from getting too high. And then there are well-known limits. So I don't think a whole body could get something like 60 Gray, but definitely in a small amount of it. And that brings us to, I guess, the microbeam effect.
Yeah.
Yeah,
So,
it's about the size again.
again, because I need to understand.
Yeah.
Traditional radiotherapy is a column of radiation.
A big, broad field.
Like so like a spotlight, there's your round circle. Here you go.
Pretty much like
Let's have a look at this
But
little sucker.
Ignore the lines for now.
Just
but
a round dot.
round dot. That's
Okay.
it.
Now, so not only are we using a really unique source of radiation, i.e. the synchrotron, what it can do,
Yeah.
and these things are huge, so there's very few of them in the world, and they cost a bit.
Yeah.
Do you know how much they cost?
Oh, I think I only know that ours is like the beamline, to run the beamline is like 30 grand a day or something like that.
Crazy stuff. So,
But
you,
it's for research. So
you guys, being super clever,
Yeah.
came across somehow or another, that's probably confidential too, that rather than just turning the headlight on and giving a big spot, you do this micro beam thing.
that's
And that
right.
is,
yeah.
what is that?
So in that way,
Let's have a look at this thing. 'Cause it
yeah,
will
I'll
go
show
up.
you this one. So this isn't a microbeam, but this is actually a mini beam, mostly so you guys can see it. But the concept is there. So instead of breaking up your dose over weeks and weeks, and what we call like temporal fractionation, or you break it up with time, we're breaking it up spatially. So it's a spatial fractionation.
Cool.
So the idea being that where you have gaps, you spare the tissue. That's what's new here. So then if you want to go after your tumor, you could send in one of these and then from a different angle send in another, and suddenly you have more overlapping.
Grid effect.
Exactly, a grid effect. And if that's overlaying at your tumor, which is what you want by design, then you can ablate that tumor without hurting the normal tissue on entry. Because that kind of thing, that's not really a big problem for our normal tissue. It's like if I, had a small cut in this case for the mini beams, but that would repair really well.
Yeah.
So this is a difference. And I guess they found out on the microbeam level only really because of things like the synchrotron, because our beam is so bright, sure, but it's so bright, and that we're 35 meters away from where those electrons actually create the X-rays. And by this point, that beam is pretty much staying in a straight line. It's not diverging anymore. And so we pass it through this really tiny collimator to make about hair-wide microbeams, so 50 microns wide. And we can get even more. Can you imagine this tissue sparing when you're only hurting one cell at a time? Just one in the pathway.
So you call it the knife, don't you? So it's a cellular knife in lines.
Exactly. A microscopic blade, we'll say.
Oh, how about that?
So there's a comb kind of like you see like this, that we kind of paint them on like that when we're treating, but it's microscopic. So this one you can see on camera, but you can imagine when it's 50 microns. And in between we space them 400 microns apart. It's about half a millimeter apart.
Got a lot more. So more tissue sparing to tissue destruction.
Exactly. Yeah. Always the way. We need to try and get some sparing to happen. So that's where it has also been really interesting to make this dose in terms of the physics behind it. Like you collimate and you get this damage in little lines. But then comes the biology, and that's really been interesting too.
You beat me to it.
No, that's good. So the biology itself is super fascinating. So we set up a whole different field now. We're setting up something that is, instead of just blasting all the tissue in its path, we're actually splitting it up. So no matter what you do with a broad beam of radiation, everything in there is getting hit on entry, on exit, right? And I don't know any other therapy in the world that does that unless you can put the radiation source right at the tumor and just get damage to the tumor. But everything else will have some collateral damage in the path of the beam. But this one, you limit the collateral damage to one cell wide.
Yeah.
Yeah. And the normal cells go, oh, that's okay. It's like a little microscopic cut, and they'll repopulate and repair that. And we've seen that from many different studies, from the cells to in vivo work. And we've been looking at how it repairs not only the tissue, but also the vasculature supply.
Yeah.
So the veins and everything's around it. That microscopic cut, that's not a problem for that kind of tissue. They're used to dealing with small damages.
So the healthy tissue around the tumor.
The healthy tissue goes, oh, that's all right. And it's got a kind of basal membrane. It's got a scaffold to rebuild over that, where that vasculature was. And it will just patch over that point and move on.
And that's super quick, isn't it?
Yeah, it happens pretty quick. Yeah.
Is it hours or days?
Hours. I think hours.
Yeah.
And even if we see something like on the mini beam level, like if you go and give blood, you've got a small needle pricking your vein.
Yeah.
That's going to be pretty much stop bleeding within,
pretty quick.
Yeah, pretty quick. So it's kind of like that. Like you're just a small little prick, but even on the microscopic level.
Yeah.
But that's the normal tissue. So we go, oh, okay, normal tissue can tolerate this. This is really cool. But then so could the tumor, right?
Yeah,
It could
yeah.
spare it. But what we're seeing is a little bit of a different effect. So with this kind of setup where you bring all of the dose from the beams into these little microscopic blades, you guarantee cell killing of the tumor
Yeah.
for sure, because it's heaps of dose in one go. It's not that 2 gray,
Yeah.
which is a really soft hit for the tumor. And some tumors just go, oh, I don't mind that, and they'll repair. This is a guaranteed like
And-
60, 100 gray.
Yeah, that's right. It's
Yeah.
really high, isn't it?
Really
Yeah.
high. So we usually do, about that 60, 100 gray. And then you guarantee a tumor cell to die in the path of that beam. This is really important because, as you know, when we get vaccinated, you inject dead virus into your body and your body learns about it and goes, oh, I can go after that. And what we think is happening is the tumor is doing a similar thing. You have dead tumor cells in the path and your body goes, oh, the immune system goes, oh, I can have that, and go and gobble that up. And they were spared too in the path of the beam where they were in the gaps.
Oh, yeah.
Yeah, so they're able to get in there and go after the tumor. If you sent out a big broad beam, it ablates the whole thing, and
Yeah.
you kill also your helpers, which is your immune system. So we know that's going on. We see a kind of anti-tumor vaccine happening.
Yeah.
And then, like I mentioned about the vasculature, that happens too, but in the opposite way. So instead of having this really like polite kind of got hit, I'm going to patch up that spot and move on. No, the tumors one is quite juvenile and abnormal vasculature. So it's quite soft and it's more fragile because it's brand new.
Yeah.
So it's got no scaffold to grow off anymore. You hit this with a microsurgical blade and bam, it's not recovering. It's struggling, and there goes your tumor's food supply.
Yeah.
So then it's collapsing because of that too. So we see some really interesting effects. There's been some studies that looked at bystander effects as well, how the cells communicate with each other in and outside the microbeams to say, hey, that could help destroy or explain the destruction of the tumor. But overall, it's this really nice balance of the therapeutic index where you get tumor really suffering and the normal tissue just happy days.
Yeah.
So that's what we really were so fascinated about, is this just by breaking up the beam, you can change the whole, scales. You can tip the balance.
But it's twofold, isn't it? So we're breaking up the beam and we're using an exponentially brighter source.
That is
So
the
we
other
can
half
put
of it.
50 times more,
Yeah.
not allowed to say energy, brightness,
Yeah, intensity.
intensity into the tumour
Definitely, yeah.
all at once instead of staggering it over time.
Yeah.
As you said, staggering
Yeah, you can
spatially.
give it in one. So
Yeah.
your patient doesn't need to sit there for minutes. So
Yeah.
to do at the hospital, like in the Linac, you would maybe do, if it was 10 gray even, or 20, let's say 20 gray, it would take 10 minutes.
Yeah.
And
You see these patients sit there. You're talking about human patients.
Yeah, that's
Yeah.
right. Not us.
Ours would be under general anaesthetic for every
Exactly.
treatment.
So what is
Exactly.
do you know how long ours are going to sit there, Ellie?
Oh, they're under
How many
anaesthetic for
seconds
a total
of
couple hours,
exposure
but
is it?
is milliseconds.
So you're looking more like 2 gray per minute is the kind of
No, with the synchrotron.
less than a second.
Yeah, it's less
So
than
the
10
exposure
seconds
time
max.
is less
Yeah.
than a second.
Yeah.
Excellent.
Yeah.
And the reality of otherwise for us, for veterinary world, there's no Linac in Victoria. So
No.
we'd be sending them to Sydney or Brisbane to try and get radiation anyway.
Exactly.
And it
Yeah.
would be anaesthetic
they're there for
4, 5, 6, 7 weeks in a row.
I
depending
don't
on the
know,
treatment
but it's
protocol.
Quite prolonged.
Yeah.
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 Well,
That's
But the other
a
thing
big
too-
multiple anesthetics for the poor animals to do all their temporal fractions. Yeah, no, that's something. And in the clinic, I know exactly. No.
But there's more to it, because not only is there the physical limitation of getting a patient to Sydney or Brisbane, there's the cost and the time cost as well as financial. But as you said, not all tumours respond that well to traditional radiotherapy, and you're starting to see response of traditionally non-radio. What's the word for non-radio?
Radiation resistant.
That's the word. So
So
radio-resistant tumours are responsive to synchrotron microtherapies.
Exactly, because you guarantee a kill in the peak, right? In these little
Guarantee is a
microbeams.
really big word in biology,
but I
isn't
don't
it?
know what happens to a cell that has 100 gray. We were talking about that before. If that was the whole body, that would be too much. But it on the microscopic level as well, it's too much.
It's a bit like the Infinity Stone guy. What did
they do.
Thanos.
Thanos,
There
yeah.
you go. So this is the
Vaporizing tumor
Thanos
cells,
of the
yeah.
radiation world.
That's right.
You are
That's right.
gone.
Yeah, it's
Yeah.
gone. It has to be gone. It's so much energy in one
But
go.
it's
Yeah.
safe Thanos rather than Psycho Thanos that needed a team of superheroes to get rid of.
To be fair, I think he did dust half the population.
Yeah,
in
yeah,
our case, we're dusting 1/8 of the tumor in one shot.
Okay, well, I guess that puts it in perspective. Now, hang on, that's cool.
Yeah.
I'm not sure if I could hang on to all that science. You didn't lose me, but I'm still with you. But there's more to it, isn't there, Ellie? Because Ellie here has this was a crazy opportunity that presented itself to me 4 years ago, I think it was, and man, it's been a journey getting there.
Yeah.
And Ellie is the second person to be lucky enough for me to go, hey, why don't you have a go? And I didn't say, oh, by the way, the person before you nearly died in the process and gave up. But Ellie was accepted that challenge. But there are so many people involved, aren't there?
Yes.
So you've just explained to me you're a physicist and you make sure the machine does what the machine's supposed
Pretty
to do.
much, yeah.
So who have we met along the way?
Actually, everyone's been so as excited and energetic as they, which makes it lovely. But there's a big team behind.
So what is it? There's engineers that put the machine together.
Yes, and build the bed and everything else. Because we need to have a moving platform.
Oh yeah, no, that's pretty. That's been one of the things, isn't it? So you can't lift up an AFL football field and turn it around a little dog.
No.
So the really big difference is that we've had to move the patient through the beam.
That's right. Yeah.
And you guys for years have been developing hydraulic tables and all sorts.
Yeah.
So it's not like we are certainly jumping on to the coattails of all your hard work, thank you. And you've got this all working and it's been done in various models and
that's
and
right.
actually it has been done in dogs for osteosarcoma already.
Yes,
Yes,
that's
so
right.
that's-
that was where we
trial's still going.
started.
Yeah.
Yeah, that's right. And in France, they did it in brain. So brain's another really awesome target for this therapy because you want to spare as much brain as possible. But also the tumors there are notorious for being difficult to kill and they are very radiation resistant.
Yeah.
So what better trial than to go for the hardest thing. Yeah. But osteosarcoma too, very radiation resistant.
Yeah. Well, soft tissue is not great with the traditional radiotherapies haven't worked that well.
Yeah.
But to get this going, it's been physicists, engineers.
Radiation planners, radiation
What's the right name for a radiation planner?
Radiation therapists. Yeah.
But we also have radiation oncologists involved.
Yeah.
That's right.
And then a raft of
medical doctors, biologists for sure, radiation biologists.
So we went to dinner the other day and the table was super long, like 20 odd people
Lovely.
all
It was
in
so
this team.
international as well.
Yeah.
Great.
It was.
So that's the other thing that certainly needs to be acknowledged. This is not just a Victorian effort. This is Burns heavily involved.
It takes a village and maybe a few countries, it turns out, to get it up and running. We have the University of Bern. They were the ones that really piloted, I guess, they were the driving force to get this going. And we really needed that help. We needed the pressure, to get it started. University of Wollongong, so we're interstate as well.
Right.
And then we have got collaborators like all over. So Germany as well, who are helping us out, radiation oncologists from Germany, and also her students as well, really keen. So physicists from University of Wollongong, radiation biologists from RMIT, as well as from, Bern, University of Bern and Wollongong as well. So I guess it takes a few, and of course the staff at the Australian Synchrotron, super keen, super helpful, so it takes a few of us and the lovely vets that have been involved so far, like yourselves, and also shout out to Southpaws too with the osteosarcoma trial. So
it's been quite a few of us getting involved.
It's amazing. It's been really cool to see so much passion into the project. As we try and cure cancer for dogs. So
the results coming through so far from that, it's like it's not finalised yet, but it's also promising.
It's
not
promising.
Just you can make a difference there or here.
Yeah.
There's going to be a lot more levels to this.
Definitely. And some of those mechanisms I mentioned, like we were really surprised with the osteosarcoma project because we thought we're giving quite a soft dose. Like we were more testing to see if it is safe, if we do have a response. So we actually started by just partially irradiating the tumour to see what would happen in field and out of field. So that's a really nice start for the biologist to see and understand the mechanisms. But what we didn't expect was, with time going on, we have not only effects in field, but out of field too. So as I was mentioning, that kind of ability to vaccinate the body with the death of the cancer, and you guarantee your death, right?
Yeah.
You've hit it with 100 gray in this case. And then the immune cells are coming in and they go, oh, I'll have that.
Yeah.
And they have the bullseye now. They can go after the rest. And so we actually saw that in 2 of the dogs. And then to boot, we had this really phenomenal effect that we didn't expect at all, which was the normal tissue response.
Yeah.
So normally I've talked about, hey, normal tissue is spared and it will just patch over that area and move on. But what we sometimes see, and I don't always see it, but now we see it in bone, is that you can also stimulate growth and repair. So instead of fracturing in absence of the tumor being there, and then because of the tumor, we had bone growth.
Regrowth,
And modeling.
Yeah.
It was
so exciting.
It was, amazing. So I didn't expect to see that. And that's been really cool. We've seen that on the histology, and then to back it up with the imaging for months along the track, we can see bone that should have fractured is back and it's strong and it's looking really, really cool. So we also seem to trigger this, healthy response in the tissue to repair, to go in and repair the damage. So some people have been asking me, oh, could you use that for osteoporosis or arthritis?
Well, they were talking about in brains for dementia, like
exactly, and
get
epilepsy.
your brain to regrow.
Yeah. So it's just to stimulate
cool.
a bit more growth and recovery by giving just this one cell of damage, and then they go up, and then they stimulate that. So the University of Bern, those guys especially, were really big on understanding these mechanisms, and they could show that too. They showed the proliferation of the tissue. The normal tissue is doing it, and the tumor is just the opposite. So we really have the scales in the right direction.
Not only well tolerated, is actually making things heal and get better.
Which is what we want. We want to see also the recovery afterward, and that was a big question. That was why we started it, to say, is this safe? Like, what's going to happen? So we were just looking for hair loss, skin burn. They're pretty normal side
After
effects from radiation.
Toxicities,
And even though we had 100 times the dose that you would have in one sitting, we had none of that because we're sparing it. So we didn't get hair loss, we didn't get skin burn. So this is phenomenal. This is what we wanted to see.
That conversation is something that I think is super important. People understand that this is not, so what we're doing with soft tissue sarcomas, it's not just some idea that just popped in our head. Let's give it a go. We'll just take client-owned dogs, pop them in front of a source of radiation that is brighter than the sun and everything else, and see what happens. This has been a process over years, and actually for this trial, and it's still within an experimental trial to get to this point to allow dogs to have this therapy. Well, you went through that. What's that process? And it's so important that people understand that this is not us just saying, hey, wouldn't it be cool? It's all legislated, isn't it?
Absolutely, yeah. So the ethical application to get all of this through has taken, you started 4 years ago. I took it over about 18 months ago maybe. But it's taken that long as far as levels of getting it right, making sure it's safe. It's based on pilot studies with some of the osteosarcoma where it's been through the safety trials.
Well, even predates that, but yeah.
And so everything like that, we have to make sure we have the right staff, the right, specialist anaesthetists, surgical nurses, vets, etc. involved, and then all the right treatment planning, trial test days the day before that are done sort of dummy runs rather than just put your dog in and hope for this.
Well,
everything is very
can we backtrack on that?
meticulously-
So the process here is that we've already CT'd these dogs, and that goes
to me.
to let.
That's right.
And you the day before actually do a trial run without obviously anything in the
we measure what we're going to give. We do some testing. I actually get some of this stuff, which is called GAF chromic film, and it leaves the footprint of the radiation, so I can see exactly where it went, exactly what I'm expecting to get, and we just make sure it's safe for them. That's pretty standard, and we do that in the hospitals too, in the clinic. You have to do your, make sure the machine is given what you're given. So that's the physicist's job. But also, it takes a team. So I have the beamline scientists helping me out with that, making sure everything's ready to go. So it is definitely not point and shoot, it takes a lot of care to get that right. And in the planning, we're actually figuring out where to put the beam, whereas like making sure we're covering the whole tumor. Because as you guys mentioned, with surgery, you can only get what you can get at, and you're pulling out what you can, and maybe leaving some behind. But with radiation, we just don't want to leave any behind. It has to be in the field. This time we're going for all of it with the soft tissue sarcoma, and we'll have margins around where that tumor is. So we need the imaging for sure. We need to plan that out and go, yep, that's our site, and let the radiation get all of it, hopefully.
And then the actual treatment itself has been completely based off all the human and veterinary literature.
Exactly.
That's out
Yeah.
Yes, that's right. So it's years and years of getting to a point where it's a known safety and a known outcome.
Yeah.
I mean, it's not known in soft tissue sarcoma specifically, but there's so much science behind it that there's a really high level of confidence that this is an appropriate tool.
Yeah, that's right.
Yeah.
And
what? Sorry.
I was going to say, through all of this, we've managed to basically get permission to treat 12 dogs. So there's 12 spots in this trial.
Yeah.
That's right.
But I'm hoping to make a really big difference to those patients.
So what does it look like for the owner and the dog? What's their experience, Ellie?
Well, we're hoping to simplify this as much as possible, basically to expect referring vets to be able to send them to us. So we'll give out our email address to me or you directly so they can contact us to literally let us know there's a case, and then they'll be able to just ring in and book into our clinic in Mornington. They'll come and see me or you, and then their dog will come in for a day with us at the hospital there, and that's where we're going to do all the initial workup in-house in Mornington, our clinic. So they'll have to have some blood tests, they'll have a CT scan, we'll have a biopsy as well at that point to actually ensure the diagnosis, but also grade the tumour and just see how aggressive it is and exactly what we're dealing with. The CT itself is going to be focused on the tumour itself and that local area so that we can do radiation planning and actually make a mould ready for the radiation as well, but also to fully check their thorax and abdomen for any sign of any metastatic disease or other things that we need to worry about.
So that's an already established standard of care in veterinary practice. Yeah.
Absolutely. And that's the thing. We're not by any means skipping any points in this. We're going to give them everything they should have.
That's the works.
But also, was it $30,000 a day to use a synchrotron?
Yes.
Also free radiation treatment.
That's right.
Which
I should say we're not.
Really good
they wouldn't expect anyone to foot that bill. The synchrotron is really supportive of research, so we have bidded for some time to fit the dogs in, and then we are free to treat, and they support that and cover all the expenses at the synchrotron. So we're very lucky in that way.
But standard expense with us for the workup.
Yes, so that standard of care is at the typical costs associated with that. But that's what this stuff really excites me, because it's how we should do it.
Yeah.
We should bring clinical problems with those patients that feed them into an opportunity to have a treatment where there really isn't an optimal treatment available, and this emerging treatment is showing such immense promise. Yeah. Isn't that just the coolest thing
so
ever?
Cool.
Yeah,
I'm so
and everybody's a winner, because science is a winner.
Yeah.
Patients are a winner.
Yeah, exactly.
It's not blue sky thoughts, and maybe it's like this really can make a difference.
That's
just
our hope
so
too.
cool.
Because we want to one day see this get to the clinical level as well.
Exactly.
And what better than to have man's best friend help us out and actually make a difference in dogs too. So this mini beam one that I've been showing you guys, they're actually doing this up at the Mayo Clinic in the US.
Yeah.
So that's exactly what they're looking at as a clinical trial now with 26 patients. And the results are phenomenal. They're seeing the same things that we are.
You are.
So I love to see that.
And that's with the
agreement.
Linac? Or?
No, it's actually just with your kind of, I guess, a bit more powerful X-ray tube. So,
wow.
Yeah, so they're actually, and I actually managed to do this at Peter Mac. So thanks to Peter Mac for that. And this is produced with their X-ray machine at Peter Mac. So it's just they call it superficial.
Yeah.
So kilovoltage radiation, and it's the same energy that we're using at the synchrotron. So it's not as high energy as the Linac, but actually we don't want that, because if you have too high in energy, those really lovely beams there spread and they diffuse out. They diffuse out. You lose that. So you actually need a bit low energy just to preserve them as they go down. And for us, for the dogs, even though it's a kind of low energy beam, it's perfect because there's not a lot of depth that we need to play with. So we're still going to give a really nice dose. We're still going to make this beautiful stripe pattern and go in and get the tumor. So, yeah.
So I cut you off, sorry, because of standards of care. So we do that prelim biopsy CT, make sure it's appropriate that they go and have their radiotherapy. We schedule a day with Alette and the enormous team of very smart people who are way smarter than us who make that all happen.
And that's going to be at the synchrotron itself in Clayton. So the animal has spent a day with us in Mornington and then gone home happy to his family again. And then from there, we schedule that day somewhere within 4 weeks of that initial assessment day.
Yeah.
We're aiming for earlier, hopefully. It will depend on caseload.
And why the 4 weeks? So we biopsy, then treat with radiotherapy and then wait. And what are we hoping?
Oh, as far as between the radiation treatment and surgery?
Yeah.
Oh, that's the next step. Because basically we go from biopsy with us and CT and radiation planning, then the radiation plan day, which is at the synchrotron.
Yeah.
So the animal will be brought to the synchrotron by its family, dropped off to the team there and be with us for 2 or 3 hours. It's probably all it's going to be for anaesthetic, treatment, recovery, little blood test, and then home. And then we're waiting 4 to 6 weeks from that treatment day to surgery. And that's where we're actually going to surgically excise the whole tumour at that point. Yeah. And that's back at Mornington with us again.
But our expectation
in that 4 to 6 weeks is that the tumour is going to shrink dramatically. We are going to be watching them really carefully for any radiation side effects, seeing them back once a week for sort of free rechecks to measure the tumour, check on the skin, make sure everyone's okay. A few little urine and blood tests along the way just to get any biomarkers, anything we need to find out about as potential side effects.
What's going on.
But then, surgery will be with us down in Mornington to actually cut the tumour out and have a look at what's happened to that tumour itself. But also they have this sort of pseudo-capsule of cancer cells around them.
This is cool too.
Really active cancer cells in that pseudo-capsule, which there has been human studies and animal studies as well looking at radiation treatments of soft tissue sarcomas, showing that pseudo-capsule becomes more fibrous and tougher and thicker with less viable cells in it.
Yeah.
So potentially what's a really messy margin is going to become a neater, more fibrous contained little bundle.
Yeah.
Potentially with an immune system there going in to mop everything up as well.
Yeah, that's right.
And that completes the circle back to the clinical challenge is that we have if we're super honest with ourselves, we have a compromised oncologic excision in these patients, even when the tumours are quite small. Like, because a 2 centimetre mass on a distal extremity right over the end of a radius on a dog technically is non-resectable. We do take them out and we get away with it, as in we cure many of those dogs. But Jesus, it's a compromised situation. So with this, even if there's it reduces in size to 1 centimetre, which still presents a little bit, a challenge from a biology perspective. If we've changed the behaviour of that pseudocapsule and we've taken out any microscopic disease, our chances of a curative surgical procedure has increased. It's just amazing.
No, it should be the perfect marriage of all these techniques, so surgery and radiation. And I do hope to see that kind of fibrousness happen, and you can better see the margins of the tumour when you're in there and get all of it. So
the thing is, we always take soft tissue sarcomas out with a 2 or 3 centimetre wide margin. This is the recommendation because how invasive they are is really tumour dependent, animal dependent. But then you're looking at these and it's like, well, they've now contained themselves. What margins do we now need? And actually, this is going to give us so much information.
Yeah.
Well, exactly. So looking forward, what's the dreams?
What's the dream, Arthur?
What is the dream?
What's the dream?
Well, save legs. It's all about saving legs, isn't it?
That's right.
And optimising care.
Yeah.
But what you've alluded to is it may mean that the dose of surgery can be reduced. So instead of these patients experience really aggressive surgical excision, they can have their radiotherapy, which facilitates lesser surgical excision, which facilitates primary closure. So we can just put the wind edges together and 2 weeks later take the stitches out and everyone's happy, versus the typical patient journey, which is surgery, multiple dressing changes, followed by skin graft, or surgery and skin graft. It's ongoing. It's a minimum of 6 weeks
No,
for these
definitely.
patients.
That's
So yeah,
Potentially very, very little, if any, morbidity along the way. Like, and that's part of seeing them back each week and seeing how their skin's reacting
exactly.
to the treatment. But
No, it
everything
will
so
be-
far is so promising.
It would be awesome because I think what we saw from osteosarcoma is I was thinking, oh, they might be sore after the radiation. But we actually had the opposite effect.
Yeah,
We had,
palliative.
palliative, I guess, pain relief from that region. And you can imagine the swelling in the osteosarcoma and quite a heavy burden on that limb. And it is a lot of pain. So that was really important too, that we could alleviate that. So I'm hoping as well with the soft tissue sarcoma that you'll see, minimal effect. And then that's right, we can hopefully minimize this really taxing experience for the pet and their owners having to drive them around and do all these procedures. So I think if we can just, that quick 2 hours visit at the synchrotron, we gave something, that can potentially cure it. And then we clean it up, mop it up with surgery, and hopefully we have a winner. That would be good.
So if I grow a cancer, can I come and see you at the synchrotron?
I've been saying that too. And we had even now.
I want my 1-day therapy and back to life, if you don't mind.
It's really actually it's a very important question because we have rural patients that come into the clinic.
Yeah.
And they're traveling so far, and depending on what kind of cancer they got, that's so much. Like they might have to turn up every week for weeks and be away from their family, and
It's life. Yeah.
it's life. Yeah, it's life. And so I think that's something really important that we can work toward, and I think that's why being able to treat not only quicker, but with something that gives you more, I guess, bang for your buck is quite attractive even to the clinical environment. And that's why some of our dogs are going to get the microbeam. And some of them are going to get this rapid dose of radiation.
So
we call that flash. That's right.
Yeah.
And that has been actually very exciting clinically as well. And that's all to do with how quick you deliver. So we hope to see that normal tissue sparing, that lack of inflammation that we get. And we're still hitting the tumor with a really nice dose that can control.
And then that's where I get excited again, because same thing, clinical problem, a real clinical problem, dogs in need, and science happening at the same time. So in this particular group, we've got 2 variants of synchrotron radiotherapy
It'll
being
be the
done.
ultimate battle. Who
That's
will
right.
win?
Who will win? But they've both been shown to be really unique with really positive outcomes.
Exactly. Yeah. Flash effect is very popular at the moment, and there's so much clinical interest. And the first human trials have already taken place, even similar things on skin.
Yeah.
So these kind of lumps and bumps again. So it's perfect. We can find out more about these cancers, with the help of our dogs.
Oh, dogs,
and still have something that we can bring, hope for the future of our cancer treatment for people. So
that's very cool.
Exciting.
Yeah. And
What
it's
about-
not just us that even takes the tissue samples as well. Like they're going.
They're going over to
business class flight over to Switzerland.
That's right.
Like, this information is
Yeah.
not going to waste. It's not just
Oh no,
treat that lump
no.
in itself. There's so much more behind
I
the
hope
scenes.
there's still some tumour left for us to get that capsule at least.
Actually, you know what? Maybe not.
Maybe not.
Maybe not. That wouldn't be the worst thing.
Yeah, no, that's right. So that's already a result in itself. But we'll look to continue down the track. So there's only 12 spots at the moment. But with we're really hopeful that we can keep it going and add to it and suss out things like, doing chemotherapy or some of these really exciting technologies that have emerged, like maybe nanoparticles as well, that can get into the tumor. Yeah.
She's just
You're
opened
well
her
above our
happy place.
average IQ. Don't say nanoparticles.
Sorry, that was
Slow
my
down.
PhD.
We've had to deal with flash, microbeam, synchrotron is bright, not
it's all
energy.
micro and nano nowadays.
Yeah.
Everything's getting smaller.
Sounds like you're sending little soldiers in to
That's
fight.
exactly what it is.
Yeah. Anyway, let's stop there because we were just getting too far. So, hang on. So, who are the patients we're looking for?
We are looking for dogs with soft tissue sarcomas on their distal limb, so front leg or back leg.
Yeah, but what's distal?
Distal limb, below the elbow or below the stifle. And it has to be basically part of the dog that we can put up on a platform and move through the beam. So that's the idea, really, because we can't move the beam around
the dog.
Yeah. That maybe will come in the future. We'll be able to move the whole dog around. And do everything.
We're also too strapped for to make a big dog stage at the synchrotron at the moment.
Yeah.
So we're out begging as well.
Oh, it's remarkable, isn't it? So you have this $30,000 a day to run this thing, and then you stand in a concrete bunker. It's completely bare.
With a stage that is moving the arm up and down.
and down,
But
and
we
that's about
want
it.
something that can move the whole dog, ideally.
This is why Annette was out practicing to walk on stilts. She's going out asking for money. Send her out on the streets. Something to
I mean, it is sad, isn't it? Because
Yeah.
science is so.
It's with
but-
research. It's
well,
so
it's just so
hard sometimes.
poorly funded.
Yeah,
but,
it is. It
hey,
is, yeah, it's
this is
so
our
hard.
little contribution,
Yeah.
and our contribution to back to the dogs as well, and to home.
No, we do what we can. That's
Yeah.
what we really we believe in the therapy, and we're going to make it happen no matter
Yeah.
what. So we'll keep trying,
Yeah.
trying and doing what we can. But yeah, it definitely takes a lot of help.
Yeah. So we have this super unique opportunity to use technology that's enormously expensive to build,
Yeah.
funded by the Australian government. Thank you,
Yeah.
whichever prime minister at the time suggested that.
Yeah.
And I mean, and a raft of science behind it.
Yeah.
Well, and really, well researched in a systematic form to get to this level where we can offer it to
Big
our
time.
patients as veterinary patients. We need the right sort of dogs. These are dogs where they really don't have the standard of care is not always going to be the best for the dog, like because of really protracted treatment periods and the compromise of actually being able to excise them surgically. So if you have patients out there, I guess let us know.
Yeah.
We'd love to know about it. And so Ellie and myself will make sure we have contact details available. I think that's enough.
I think so too.
Yeah.
Okay, now that's a vet wrap, and I'd like to remind listeners that there are future podcasts coming up, and huge thanks to Ellie and Alette, and I hope you enjoyed that session. And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.